Cardiovascular risk associated with testosterone replacement therapy remains a topic of hot debate. In fact, I've always maintained that there are mechanisms by which you can cause cardiovascular events in patients on testosterone, but I've also maintained that those risks are mainly modifiable if patients are handled by a physician that's experienced with treating such high-risk patients. Unfortunately, because of the low standard of care in the United States, I predicted that there would be, in fact, papers showing increased risk when patients are treated with testosterone replacement, and particularly studies that had the following characteristics. Risk will appear early, consistent with being related to clotting events. Studies would utilize high-dose regimens. These studies would be characterized by poor initial and ongoing evaluation and intervention for modifiable risks, and would be most pronounced in populations at higher risk for cardiovascular events. In fact, the minority of studies that have demonstrated increased risk conform to these expectations, with the exception of one trial that indicated increased formation of soft plaque over 4 years on testosterone replacement therapy. On the other hand, a recently published double-blind randomized controlled trial has been good news in regard to this risk. That is, this trial examined the risks of cardiovascular events in patients on TRT who either had cardiovascular disease or were at high risk for developing cardiovascular disease. In fact, it showed that testosterone replacement was not associated with increased cardiovascular events. Now, what they define as cardiovascular events are what is referred to as MACE, major adverse cardiovascular events, that is non-fatal stroke, non-fatal MI, or cardiovascular death. On the other hand, while it's great news, this 4-year study has to be taken as preliminary for a number of reasons. First, the dose utilized, which was appropriate for a preliminary study of high-risk patients, was likely suboptimal in regard to providing testosterone benefits. In fact, achieving levels from 326 to 386 nanograms per deciliter at trough. And this also, of course, could lead to potentially underestimating the risk in patients that are treated with more robust treatment. In fact, our long-term dose-ranging observational research is consistent with what currently available published studies indicate, which is that most men achieve optimal symptom relief and health benefits in the top 1/2 to 1/3 of the physiologic range. Secondly, this study had a dropout rate of 61% in the testosterone patients, which is concerning and may compromise the strength of the conclusions that can be made from this data. Thirdly, a higher incidence of atrial fibrillation, acute kidney injury, and pulmonary embolism was observed in the testosterone group. While the acute kidney injury is likely not real, atrial fibrillation and pulmonary embolism are more concerning. And this is especially the case when studies looking at the risk of pulmonary embolism have indicated that this typically occurs in people with thrombophilias, something these patients were not screened for. Thrombophilias, that is, are conditions that increase your risk and susceptibility to clotting. Further, as there are a multiplicity of mechanisms supported by a large body of science that indicate that testosterone should result in positive effects on the cardiovascular system, it's concerning that TRT in this study was not associated with less risk than the placebo. If such benefits exist, then adverse events did occur in this trial that nullified the appearance of cardiovascular benefit on testosterone replacement. Now, it's also possible that the brevity of this trial, 4 years, may account for some of this effect, as many mechanisms that I believe improve CV risk on TRT have to do with things like effect on prediabetes and diabetes, the improvement in muscle and fat mass, improvement in mood, improvement in energy and motivation to exercise, etc. And there are benefits that would be expected to accrue and continue to increase over many years. Finally, though this study was designed better than many studies in the past, and it certainly provided better quality of care than the low current standard of care in the United States, the protocol for risk assessment modification was still inadequate, especially for these high-risk patients. Long-standing DTRC protocol for CV patients is more comprehensive in regard to identifying baseline modifiable risks and addressing them prior to treatment initiation, to the number of risk factors for which monitoring and intervention is mandated during treatment, and it contains stricter criteria for which intervention is triggered for hematocrit elevations, which are the most common side effect on testosterone replacement. Therefore, I argue that a similar trial should be conducted, but with the following adjustments or characteristics. The study should have dosing of testosterone such that it achieves more robust levels of testosterone, again targeting at a minimum the upper half of the physiologic range and preferably the upper third. It should provide for evaluation of patients at baseline for modifiable risk factors such as sleep apnea, hypoxemia of any cause, genetic and acquired thrombophilias, genetic mutations that cause clotting, and medications that raise hematocrit, etc. Risk factors identified should be modified where possible prior to starting TRT. The hematocrit on TRT triggering aggressive intervention should be lowered from 54% to 50%. It should provide for regular monitoring of estrogen levels and for intervention for elevated estrogens. It should mandate vigorous surveillance and intervention for any sign of fluid overload. There should be ongoing monitoring for nocturnal hypoxia, and it should be designed so that subgroup analyses can be performed to look at the effects of estrogen and hematocrit levels on the risk of cardiovascular events in patients on TRT. In the meantime, we maintain that treatment of such high-risk patients should be A, looked at as experimental, B, understood that it should only be done in a context where the time can be taken for the kind of comprehensive evaluation and initial ongoing monitoring that are needed to treat these patients appropriately and safely. And thirdly, that such treatment should only be delivered by physicians with a lot of experience and expertise in treating high-risk patients. Thank you.